Thank you, Christoph, for the introduction, and thank you for inviting me at this conference. I'm a little bit afraid, but not so much due to my age. After the Zorida speech, I risk to be unemployed as a surgeon, but fortunately, the future is not so close. Maybe we need some more time to be unemployed as a surgeon. And as a surgeon, we have to provide to our patient the promise that we share with her at the beginning. I don't think that nowadays we have what we call, a standardized procedure. Not ever. Maybe 20 years ago, 15 years ago. I remember when I was young, many years ago, we were working together in the 70s with Professor Veronesi in what we call conservative surgery, as Fisher started in the United States. And we were working with the Russian Institute of Breast Cancer in an enlarged mastectomy. Compare the patent mastectomy and the large mastectomy in the 70s, where we are talking and thinking about conservative. So, just to introduce you the problem of breast cancer from surgical point of view. So I had to discuss about our experience at the National Cancer, and now I'm working in a private. I'm retired from National Cancer for many reasons. I don't go inside with you. And these are my disclosure. I'm a temporary consultant, and my books on plastic surgical procedure and videos, just to allow people, to go in depth with this kind of particular surgical techniques. So when we face the problem with our patient, first of all, I think that we must go in depth with women and we share with them everything. I used to say that nothing is magic in surgical procedure, and the only one option is to have a well-informed patient and technically prepared surgeon. When inform him that we have to share everything, and the last decision making is made by the patient and not by the surgeon. And this is mandatory if we want to reach great results from every point of view. So just to show you at the beginning, Cochrane, that is a radiologist, senologist, showed which are the limit to have an acceptable result in breast conservative surgery related in the inner quadrant or lateral quadrant, just evaluating the ratio between tumor size and breast size. That's it. And then we started creating the algorithm related to the tumor size. If it's not more than 2 centimeters, assess the volume. If it is very small, for example, maybe it's better to go to what we call maxillary mastectomy according to the patient, unless you have to warn the patient about a very unpleasant final result, because the promise is, I can preserve your breast, and now that the patient think about a normal breast, and not something like that. So this is mandatory. Everything must be pointed out. And so I said the volume, it is easier. If you have a medium breast, you can relate it to the ptosis. If you have no ptosis, you can make a wide open resection, going there with the patient about the final symmetry. If you have a ptotic ratio, it's better to try to reshape both the breast, unless you run a very high risk to have asymmetries. Again, the promise was local control and cosmetic outcome. If you have a very big breast, a ptotic one, I believe that the only one procedure is bilateral mastoplastic reduction, as like as in aesthetic surgery. Nowadays, there are no differences at all between reconstructive procedure and aesthetic procedure. They are working together. Same surgical techniques, same tools. Everything is similar. And now, this is the reason why nowadays we have not to speak in two different fields, reconstructive and aesthetic surgery of the breast. And so the anatomical bases are fundamental for the resection. And we are talking about now, but don't forget what Peter published years ago. You know, very few local roulexes, but 1 out of 4, you know, can die for a local rolex after conservative surgery. 70,000 women treated in clinical trials have been analyzed by people. And there is no other work nowadays showing these differences. Go ahead, coronectomy, you have to keep in mind the vascular, blood supply, unless it's very difficult how to plan everything, to remove and to reshape the breast. And we know that all the area around and the central coronectomy, you know, we have different kind of blood supplies like as nervous, you know, anatomy. Don't forget, if you want to preserve the sensitivity of the nipple and the renal complex and all the other breasts. And so the breast volume, the tumor size are your driver in, you know, how to choose the best surgical procedure. Again, I used to say that this is the no man's land. You cannot move your neck in that area unless you have an unpleasant result. You can, you know, remove, but you cannot hide the scar. And you can fill that area, but take care. Again, the paradigm are measurements. This is a local relapse. If you don't make your project before with the patient in a standing position, it's very difficult when she is lying in operating theater. And I suggest to put the patient seated all the time at the end of your surgery, just to check if your work has been done perfectly. And again, just to show you some measurements and final result immediate after surgery. As you can see, we cannot hide the scar in the superior quadrant, but you can feel it, as like at the contrary. Again, measurement, as like is in a aesthetic procedure. There is no difference at all. If you know very well how to measure, how to check the breast, the symmetry, you can do everything according to the patient. Don't forget, according to the patient. So what we have to do when we do something we would not have to do. So, amazing. I promised at the beginning to preserve the breast, to control the local, and then I use a DIF to try to solve the problem. It's against our promise. It's like this kind of result. These are not breasts at all. So what we have to do? Surely we can remove, as I showed you before, a great amount of breast, and you can rebuild it. That's the reason why aesthetic surgery and reconstructive surgery are so close nowadays. I used to say that we need vertical surgery and not people working in different areas that try to work together, and sometimes, you know, they cannot share the patient before. And so you can reshape the breast, but the main important thing is to try to have in your hand the blood supply. If you know very well the blood supply, you cannot run any risk to lose your surgery, but above all, to lose part of the breast. And everything is coming from the internal artery mammary and from the external artery. And so, you know, perforator are coming from the inferior part, and everything can be planned. As like as the anatomy of the breast. The fibulus septum, published first by Phil and then by Andy, showing that we can remove the inferior part of the breast with a great reshaping of the breast itself. And again, central quadrantectomy is a particular area. Again, assess volume, everything can be planned before in Europe. We will see during the day many different possibilities to use an algorithm, you know. But small, medium, I try to inform the patient that the result can be not so good. Maybe it's better skin sparing. Why skin sparing? Because it's close to the nipple and the area. And in medium size, we can use what we Risotti used my chief before, a lateral reshaping, or in a large entropic breast, I use two different pellicles, you know, as in a mastoplasty reduction. So again, in a central quadrantectomy, don't forget the blood supply, and you know, try to use your tools in the best way, and with a lateral flap, you can rebuild your breast, just to show you the project before, you know, and the final result after some years. So you don't need some time to shape the contralateral one. You do the nipple, and you can rebuild it after, you know, radiotherapy. You can use double pellicle. You remove the central part, the neck, and then you can use the superior pellicle to recreate the areola, and the inferior one to fill the central part. And again, just to show you some patient after radiotherapy and the neck, you know, reconstruction. Just a movie, you know, we can run a little bit, you don't need everything. Measurement, it's like as a tailor, not so many difference. It's really important how to move the breast, as like as in aesthetic surgery, but just to show you that the option for this patient were two. One, the lateral part, and one using two different pellicles. It's the patient that can decide in the end. She decided to have a small surgical procedure, not to touch the other one, and so we use what we call lateral, you know, reshaping by a dermoglandular flap. I maintain this, you know, skin to rebuild the areola, and just as fast you can, you know, it's easy. It's like as in a mastoplasty reduction, cut the derma, you don't have any problem. The blood supply comes from, you know, the perforator, and again, the first stitch is just to give the first reshape, and a suggestion, if your flap does not move very well in the central part, this is a back cut. It's a very easy thing, use in plastic surgery. I was born as a general surgeon. I did a lot of general surgery in National Cancer Institute, and I moved in aesthetic surgery in the 80s. It's just the back cut to solve the problem. Very easy things. You don't need, you know, miracles, but just few things to make it greater. Again, reshape the skin around the new areola so you can obtain it in the best way. And this is the final result after surgery. We can run a little bit, again, inferior quadrantectomy, don't forget the blood supply. It's very easy, as you know, Madi showed you before. If you don't do that, you cannot achieve any kind of result as a normal breast. And so it's like as in aesthetic surgery, when you need to carry out a Pitangui technique or some other, you know, it doesn't matter when. But this is the final result after radiotherapy and everything. There is a small difference, but acceptable result. And you have to go in there with the patient if she wants to exploit, you know, the surgery in order to improve the final result of the heavy breast and toxic one. You can use a bilateral approach. Why not? You know, it's a sort of for the patient, you know, a mechanism to try to forget the breast cancer in any way. And again, after years, many different solutions in internal or inner or external quadrant. The inferior quadrantectomy we can run, you know, and go ahead, Madi just explained to you. Maybe we can spend some more words related to superior quadrant and superolateral. Again, don't forget the blood supply. When it is medial, sometimes it's very difficult. You cannot avoid the scan in any way, but at the end is acceptable. It's related to the breast shape and size again. If you have a breast like this one, is easier. You can remove whatever you want in the inner quadrant, and you can have a final result as like as a mastoplasty reduction. So, you know, everything is different. It's related, as I said to you, the first driver is breast size and breast shape related to the breast cancer volume. Again, sometimes even in an inner quadrant, you can carry out a perfect quadrantectomy, a perfect suture as you can see in the left breast, and it's better the treated one compared to the other one. The superolateral is surely easy to reshape, as in this patient, is not so difficult, it's enough just to reshape. What I suggest you, in this patient for example, is just to centralize the nipple and the areola complex, that's it. You don't need to do many things, that's very easy. You know, I start just to decipitalize around the areola in order to be sure. I take my measurement, we can run. I don't want to show you what does it mean, sentinel node biopsy. Again, the quadrantectomy, can you see? I start from the areola, just to be sure to move and centralize it. And then I remove, the quadrant, and again, I suggest you to go try to the pectoralis major, and then you have in your hand all the quadrant in the tumor. It's easier to control the edges, and you can resect it in an easy way. Very few maneuvers, but you can easily reach the finding. Just harvest a little bit to close better, your quadrant, and again, I don't go ahead in, but it's enough just, to have some tissue to close in the best way, and again, just suggest how to reshape in the best way the nipple and areola complex. This is a really easy procedure, but that can allow you the best result that you have. Just to show you, can you see? I use a pulsing incision, Gore-Tex, if you can, is better, and I close, and then I remove all the wrinkles around, so you can avoid any, unpleasant result close to the areola. That's it. Then it comes out, and it is very easy to obtain a great, and this comes from aesthetic. That's the reason why, if you are a breast surgeon, you must know very well aesthetic breast surgery. Unless you cannot obtain, this is an immediate post-op, and this is at the end after 1 year, just to show you, the patient does not have any problem, any retraction, you can centralize the nipple and areola complex. Again, you can use many different solutions, superior lateral pedicle, and move in the internal superior part, your inferior part, or use an inferior pedicle to try to reshape the breast like is in this patient. This is an immediate post-op, good, as Mary, warn you, take care to the radiotherapy. Not every breast has the same response. Above all, the breast, a fatty breast, can, be worse than some other. Different solution. Some patient is not, concerned about bilateral in immediate situation. Then they can rely that she needs to, in any way reshape the contralateral to get the symmetry. You can do it in a 2 stages approach. And again, also in elderly patient, you can reach great result. She doesn't want to be touching the other one. Again, superior pedicle. You can program everything. You can see red cancer, black skin incision, green radical excision. I want to be sure in any way. It doesn't matter if it's enough 1 millimeter or 4. If I can reshape my breast according to my patient, I prefer to take out 1 centimeter in any way. It doesn't matter. I'm sure. I completely agree with you. But if I can reshape the breast in the best way, why not? And as you can see in yellow, the inferior pedicle, brown, a sort of scrub, that I can close, and this is the final result after surgery. Not so far from aesthetic. So everything can be managed in the best way. And again, you can use the central part of your breast to remove all around. And like in this patient, sentinel node, superior internal quadrant, the resection, you can move your breast as in a binary approach by what we call parallel skin incision at the end of the surgery. See the patient, unless you cannot see, that's a final result 1 year later. See the patient. I repeat every time, sorry, but it's really important. Mirror quadrantectomy, when we are working together with Professor Veronese, he said to me, but why we cannot do bilaterally in order to analyze the contralateral breast in the same way if there is any lesion? And in this particular bilateral approach, we found, for example, I forgot the data at home, but just to show you the bilateral approach in a what we call mirror quadrantectomy, but we found more or less the 80 to 10% in the contralateral initial, as introductor or something like that, in the contralateral breast. Again, so just to show some time, if you don't discuss before, you can find, if you are a plastic surgeon, after a resection like this one, if you don't manage everything in your hand, it's hard to try to give a shape, a mound of this disaster from, resection. But working in this way, you can obtain it every time. Bilateral approach, in my personal point of view, the best approach, even in a very young patient like this one, to try to get the final result, even after radiotherapy. This is our first approach. We analyze 100 patients at the National Cancer Institute, and this is the timing. We don't observe any increase of local relapses, and we are talking about, I have to talk about cosmetic, and just to suggest you, the best procedure is dermal glandular flap before radiotherapy. After radiotherapy, sometimes you can have some disaster that need muscular channel flap. And again, the best solution is immediate reshaping. You cannot close in this way, but use some surgical procedures like is in aesthetics. And delayed reshaping, take care. It's not so easy. Use a very huge pedicle for try to get the best blood supply, unless you can run the risk to have a very dramatic necrosis of your flaps. And so this is a new way of thinking, even now. I don't completely agree with Madi about the oncoplastic. I completely agree that Aldrich was the first that introduced this new word. Maybe at that period of time was even Scott, but nowadays oncoplastic does not mean to reshape the breast after conservative surgery. Oncoplastics mean a vision of cancer treatment according to the patient, who is the central of decision making, to use the best solution for cancer control and cosmetic outcome. Conservative mastectomies that I introduced in 2009 is a part of oncoplastic procedure. Mastectomy is an oncoplastic procedure. So, new style of working altogether, new strategies from every point of view, and new opportunities. And a reconstruction procedure must be part of the breast cancer treatment. This is a sentence that was out after a consensus workshop in Florence in '99, so more or less 20 years ago. And advertisement, as everybody, this is our meeting in Milano in aesthetic breast surgery. Each other year I organize aesthetic and oncoplastic. Why? I believe that we need to learn more in aesthetic nowadays than in oncoplastic surgery. Thank you so much for your attention.